Okay. Well, I'm Cristina. I come from Spain, from a hospital that is in the southwest region. This is my hospital, and I'm going to talk about the hearing aids and hearing devices we have now and we use now in this technological era. Now and then there are more advances and new devices that we can use. So I'm just going to go through them. Just click. Okay. So I'm gonna go through some clinic cases. If we had in the clinic this lady with this otoscopy, which is normal, and this audiometry, we can all agree. The previous one. Okay. We can all agree that she wouldn't need any hearing aid. What if instead of this audiometry, she had this one? So for us in this case, she wouldn't need anything either. And if in this case with low frequencies, with hearing loss, she wouldn't need either. But if she had the full in the medium frequencies, in the conversational ones, then yes, we would recommend a hearing aid. In this other case, with this otoscopy with some chronic otitis media or a perforation, and this audiometry with air bone gap, if the ear is dry, we can recommend a hearing aid. But if we had this other otoscopy instead, we wouldn't recommend a hearing aid, and we would recommend instead maybe bone conduction implant. This other case, we would recommend a hearing aid in the left side. But if she had any kind of issue in the skin or skin problems, we could substitute the hearing aid for transcutaneous bone conduction implant. In this other case, for her, first step, most of the times, we can recommend a hearing aid. It may function good and give her this air conduction, so this one would do the work. But if the hearing aid did this other hearing, then we could propose a cochlear implant, because this one wouldn't be making the correct hearing. So we have different solutions, starting from the classical hearing aids. We have the cochlear implant, we have the bone conduction implants, and we have middle ear implants. The indication for the hearing aids, we will indicate them in patients that have hearing loss greater than 30 decibels at conversational frequencies, which are frequencies from 500 to 2000. Especially, we will look at the ones of 1000 and 2000. This is a scale we use. Actually, we set the normal acusia at 30 decibels. In order to start thinking about a hearing aid. There are different types. We'll choose them in order of the preference of the patient, the grade of hearing loss they have, or just if they have any problem, skin problems or something, ventilation problems in the ear. So for us, it's really important to do an early prosthetic adaptation, because it allows improved discrimination, stimulate all frequencies in the auditory system. It will minimize the distortion. It will give the patient as much auditory information as possible, and it will avoid or at least limit the effects of the sensory deprivation. They do work and they do an excellent work, but still they have limitations. So in order for them to work correctly, the patient will have to keep some things in mind, like they have to have a good distance with the interlocutor. The interlocutor must always do good vocalization, and the environment should be not noisy. The bone conduction implants. These implants do direct stimulation of the cochlea via bone conduction. We have different types. We have the actives and the passive ones. In the group of actives, we can have them percutaneous, which do a permanent wound in the skin because they have this abutment that will go through the skin, and we have the transcutaneous that won't leave that will leave intact skin. So we will indicate the bone conduction implants in conductive loss. They will close air bone gap. In mixed loss, they will close the air bone gap and also compensate the sensory neural hearing loss. And in the cases that we have one healthy ear and one that doesn't work. So for the active and percutaneous, the Baja and Ponto, they're implants that have a titanium abutment that is anchored to the bone. We will indicate them with conductive or mixed hearing loss that don't go above 65 decibels. In case we want to do cross effect, the healthy ear should have at least 20 bells threshold. In this group, we also have different types that can get to different thresholds. For the transcutaneous one, we have the bond bridge. So we will indicate it in conductive and mixed hearing loss that don't go above 45 decibels. For the cross effect, the same as the Baja, the healthy ear must have at least 20 decibels threshold, and it's not indicated in kids under 5 years. For the osea, that is similar to the bone bridge, the indication is conductive or mixed hearing loss, not above 55 decibels. For the middle ear implants, we used to have the Carina. We actually have one patient with it, but it's not longer available. Now we have the Vibrant Sound Bridge. What do these implants give us of advantage is that they give good gain even above 8,000 hertz. They do no feedback due to the great distance between the vibrator and the microphone. They eliminate external resonance, so there will be less distortion, and they're really small or invisible behind the ear processors. So the implant transform the acoustic signal into mechanical signal that moves this thing that is the FMT, and that directly makes the ossicle chain vibrate or the round window. We will indicate them in mild severe sensory neural hearing losses that associate external ear pathology, or in mild moderate mixed hearing loss after middle ear surgery or due to malformation. So in the case we have a mild to severe sensory neural hearing loss, we will put the device in the long branch or short branch of the incus. We have some selection criteria. The patient has to have at least 50% in verbal audiometry. For the conductive and mild moderate or mild moderate mixed hearing loss, we will put the device in the round window or in the staples. There are also some criteria. They also have to have 50% in the verbal audiometry. And The last one, the cochlear implant, it does electrical stimulation of the auditory nerve. The indications in adults, we will indicate them in severe to profound or total bilateral sensorineural hearing loss at conversational frequencies in adults with a life expectancy of more than 3 to 5 years. When there has been a hearing deprivation that lasts more than 35 to 40 years, we will individualize each case. The main thing you have to look at is that they have been using a hearing aid for at least 3 to 6 months, and that hearing aid will make no or minimal benefit, and that would mean that in the audiometry they won't take greater than 50 decibels at conversational frequencies. They will also have to do a verbal test, the syllable verbal test, and they have to not get more than 40%. In the case of the kids, we will indicate it in severe to profound bilateral sensorineural hearing loss in kids aged 5 to 17 years. Kids under 5 years, it is indicated for profound or bilateral hearing losses. The ideal age to recommend the cochlear implant in kids is before 2 years. And it doesn't matter if the kid has already started talking or not. They do also have to try first the hearing aid for 3 to 6 months and demonstrate that it gives no benefit or minimal benefit to have an audiometry that won't give greater than 50 decibels, and the syllable test with a recognition less than 40%. I'm going to show you the outcomes that we have about bone conduction implants in my hospital in the last 6 years. So we use the bone conduction implants for ear canal atresia or ear atresia, malformations of the ears, and otosclerosis, and we do use them too when we have just one ear working to the cross effect. In the last 6 years, we have had 45 patients that have been operated with a bone conduction implant. The way we work, the protocol is we see them in the clinic, then we have this trial test where we can give them the soft band. They can take it home for a week, and afterwards they will tell us if they're satisfied with the hearing that it gives them. Sometimes we will have a CT scan. We won't ask for it just only for the implant, but if we have it, we can see the width of the bone. So our study had 45 patients, 18 men, 27 women, with an average age of 49 years. Most of our patients had mixed hearing loss, the 44% of our patients. The most common pathology in the ear was chronic otitis media. Then we had some with sudden hearing loss. In the case of conductive loss, the PTA gain with this device was 33 decibels, and in the mixed loss, PT gain was 45. The grade of satisfaction of our patients after putting the bone conduction implant was 93.9%. 93.9 had good adaptation afterwards. In the case of the cross effect, the satisfaction was not that great. 4 of our patients did not get good results and ended not using the device. For the Baja, that is the one that we use the most because we live in a dry area and we don't live by the sea, so our patients they don't have much problems with the abutment. We usually use the Holder classification to talk about our skin complications. There is a new one that came last year that is from Portugal, and they will tell you what treatment to use in order of the complication. So just to conclude, for conductive and mixed hearing loss, we did get really good results, and 93% of our patients were satisfied with the hearing solution. In the cross effect, it was more complicated. And last, I'm just going to show you this study I did about the audiometry and hearing tests in the phone with an app. So we all know that the audiometry is the gold standard for hearing detection and to diagnose hearing loss. They do require a soundproof environment, the comprehension of the test, and the patient disposition. So the objective of this work was to compare the results that we get in our cabin, audiometry cabin in the clinic, and the one in the phone app. I did them both in a soundproof cabin in the same one, using the audiometer and then a phone app, concretely the Mimi app. In the case of the phone app, the hearing devices were AirPods Pro. We studied frequencies from 250 to 8,000, and just studied the air conduction because the app didn't have the bone conduction. So the study had 35 generous colleagues that didn't have hearing complaints and that had normal otoscopy. We had 23 women and 12 men with an average age of 25 years. So we did the otoscopy to check that they had normal otoscopy, then did the audiometry test in our audiometer, and then the one in the phone app. This audiogram is the one that gives that the phone app gives, and this is the one that our audiometer gives. So I did a statistical test to compare them. This is the app. The app requires to be in a silent environment, so it won't work if there is noise. It will tell you that you have to look for a quieter place. This is the audiogram it gives. So it has limitations because it's more difficult to do this test. It's quite longer than the one in the audiometer, and you can easily fake the results. So I compared statistically with the intraclass correlation coefficient. This coefficient gives you results from 0 to 1, meaning one that both tests you're comparing would be really similar, nearly to the same. So we did get some that were really similar, but not all. The better results were in the right ear and in the high frequencies. We don't know if it was because of the AirPods or something in the app that wasn't working. So in the end, we concluded that we couldn't rely on it, and it wasn't like the same as doing it in the clinic. But we thought that it might have been interesting and helpful because we cannot evaluate our patients if they don't come to the clinic to do the audiometer. For us, the first thing a patient does when they experiment hearing loss, they go to the primary care, and as the doctors there don't have audiometers, they will always send them to us. So we have lots of patients with suspected hearing loss, and lots with just tinnitus that they have to come only because they need the audiometry. So if they had something that could test their hearing, maybe those patients wouldn't have to come to our clinic. Also, we thought it could be useful for emergency situations in which we would like to test the hearing, like in sudden hearing losses or in many illness in which the hearing is always changing, so we could just record the changes. And also just to follow patients that have normal ear but keep getting hearing loss. So for the future, we'd like to inspect like the whole phone app market. There are lots of advances in this area, so they will get there. We will try also to use another device for the listening. Maybe headphones will be better than the AirPods, and maybe we will try to do it in a healthcare area and see how it works. And that's all.
Thanks very much, Cristina. That was a wonderful talk. We'd just like to take it to the floor to ask if there are any questions.
No.
Okay. No questions from the floor. Thank you very much, everyone. Have a good Wednesday.